I think it's important to make the distinction between infects and affects the nervous system. COVID infects the nasopharynx very well. It causes loss of smell and taste through infection of our nasopharynx. Parts of that nasopharynx have direct extensions into our brain. The olfactory bulb in our head sits right above, straight through there, right above our eyes, dead center. And our nasal epithelium has processes that extend up into the olfactory bulb, and those could be a natural conduit for the virus to move from the nasal passages into the brain. We know viruses do that. Herpes simplex does that very well. So the hypothesis was that maybe COVID could do that. I think the evidence is pretty much against that now. There are certainly some signs that COVID are in the brain. The very sensitive PCR technology can detect some virus in the nervous system, but whether it's really in the nervous system or just in the blood, I think is a question that will basically play out in the next year or so. That said, just like the other previous examples, the virus doesn't have to get into and infect the brain in order to affect the brain. And the way it seems to be affecting the brain is causing coagulation disorders, and these lead to strokes and infarctions in the brain. This can be a significant component of brain degeneration, as we've seen in other dementias. So it can act as a stressor and cause secondary degeneration of the brain. It's important to make the distinction, though, because if you want to design therapeutic approaches to it, it's important that you know what you're designing the therapy for. You're not designing the therapy to stop viral replication in the brain. That's not happening. What you're trying to do is stop the coagulation disorder.